Imagine for a second that you are living with a chronic, intensely itchy, and, well, just painful skin condition.
Oh, it's miserable.
Right. And it causes your skin to become this porcelain white color. It gets scarred, atrophic.
Extremely fragile tissue, yeah.
Exactly. Now imagine that the standard treatment, which is usually these really strong steroid creams, it just simply isn't working anymore. Or maybe the condition has spread aggressively across your entire body.
Which does happen, unfortunately.
It does. So where do you go from there? Today, in this deep dive, we're talking about a condition called lichen sclerosus, or LS. It typically affects the anogenital region, but like I said, it can spread.
And when it does, it's a massive clinical challenge.
Right. So our mission today, the big question we're looking at is, can oral JAK inhibitors, these really targeted systemic pills, be utilized in the treatment of severe, generalized, or refractory lichen sclerosus cases?
It's a huge shift in the landscape. I mean,
Right.
we are looking at a radical pivot away from the traditional, highly toxic fallback drugs we used to rely on.
Yeah, and we have a really dense stack of sources to guide us through this. We are starting with the established baselines, the 2014 UK BIHH guidelines, plus the recent therapeutic updates from the European Academy of Dermatology and Venerology.
Great foundational texts.
For sure. And then we're jumping into the cutting edge stuff. We've got current phase 3 clinical trial data on JAK inhibitors and these incredible specialized case reports published in Frontiers in Immunology and Curious, literally right up to 2026.
The new data is just fascinating.
It really is. Okay, let's unpack this. Because before we can look at the cutting edge pills, we kind of need to understand why doctors are looking past the current gold standard.
Right, the ceiling of standard care.
Yeah. I mean, clobetasol propionate is the gold standard for a reason, right?
It is. I mean, clobetasol works exceptionally well for the vast majority of patients.
Okay.
When you apply it consistently to localized anogenital lichen sclerosus, it heavily suppresses that local tissue inflammation.
Which stops the itching.
Exactly. It halts the intense pruritus, and it prevents those aggressive architectural changes.
Yeah.
You know, the tissue fusion, the severe scarring, that porcelain white atrophy you mentioned earlier.
Right.
But crucially, and this is so important, it also reduces the risk of vulvar cancer.
Wait, really? The cream prevents cancer?
Yes, because chronic unmitigated inflammation in LS, it basically creates an environment that's ripe for cellular mutation.
Oh, wow.
Yeah, which can lead to squamous cell carcinoma. So by suppressing that inflammation locally with the steroid, you directly lower the malignancy risk.
No, that's incredible. But the clinical efficacy kind of drops off a cliff, right? Like when we look at refractory cases.
Absolutely.
Where the immune response just seems to override the cream. Or in generalized cases where it spreads to the trunk and extremities.
Right, because the logistics of that are just impossible.
Yeah, asking someone to apply a super potent steroid over like 40 or 50% of their body surface area, that's just clinically unfeasible.
It is. You introduce this massive risk of systemic steroid absorption. You get adrenal suppression, widespread skin thinning. It's dangerous.
So what do doctors usually do then, like currently?
Well, historically, if a dermatologist faces a generalized or refractory case, they've had to prescribe these really broad systemic agents.
Like the immunosuppressants?
Yeah. We're talking drugs like methotrexate or cyclosporine or oral retinoids like acitretin.
Right.
The problem is their efficacy is totally unpredictable and their toxicity profiles are severe. Methotrexate, for example, it interferes with DNA synthesis across the board.
It's like using a sledgehammer to fix a watch.
That's a perfect way to describe it.
Or, shutting down a city's entire power grid just to turn off one faulty porch light. You suppress the whole immune system and you bring on all this collateral damage, right?
Exactly. Opportunistic infections, liver toxicity, bone marrow suppression, all to quiet down a localized skin issue.
So isn't there a way to just sniff the specific wire causing the problem?
Well, that's exactly where the science is heading. We are moving away from broad immune suppression toward highly specific intracellular targeting.
Okay, so to understand how we target it, we need to know what's actually causing the itch and the scar in the first place, right?
Right, the specific pathology of LS.
Let's get into that.
So LS is driven by what we call a Th1 type immune response.
Okay.
You basically have this localized autoimmune dysregulation. These Th1 cells flood the tissue with inflammatory cytokines, mostly one called interferon gamma.
Interferon gamma, got it.
And these cytokines are essentially little immune messengers. They tell the body to ramp up inflammation, which leads to cytotoxic damage and all that severe scarring.
So they are painting a target on the skin cells.
Exactly. But the crucial detail is how that interferon gamma signal actually translates into cellular destruction.
Right.
The cytokine binds to a receptor on the outside of the skin cell, but the signal still has to cross the cell membrane to reach the nucleus.
Right, to actually alter the gene transcription and start the attack.
Yes. And that intracellular relay system, that is the JAK-STAT pathway.
Okay, here's where it gets really interesting.
Yeah, so Janus kinases, the JAK-like proteins, they are attached to the inside of these receptors. When interferon gamma binds on the outside, the JAK proteins on the inside phosphorylate STAT proteins.
Right, I was reading this and I was thinking about it like a cellular switchboard.
It's switchboard.
Yeah, so if the cytokines are the callers, trying to order an inflammatory attack,
Okay, I like that.
the JAK proteins are the switchboard operators. And if you introduce these small molecule drugs, the JAK inhibitors, they basically unplug the switchboard.
And they drop the call.
Exactly. The interferon gamma can bind to the outside of the cell all at once, but the signal never reaches the nucleus. The attack is just canceled.
That is exactly the mechanism of action. Because these small molecule drugs work inside the cell, they unplug that switchboard before the cell can even react.
That is so elegant. So now that we know how they work in theory, we need to look at what happens when severe LS patients actually take these oral JAK inhibitors.
And the real-world evidence is just wild. Let's look at the case files.
Yes, the 2026 report in Frontiers in Immunology.
Right. It details this really instructive case of a 62-year-old woman. She had a 2-year history of refractory generalized lichen sclerosus.
Her clinical presentation was awful. Lesions across the trunk, the extremities, the vulva.
Yeah.
She had completely failed all the conventional creams and those traditional systemic fallbacks we talked about.
Right. She was out of options. So the clinicians intervened with 15 milligrams daily of oral upadacitinib.
Which is a selective JAK1 inhibitor, right?
Exactly. And that selectivity is vital. By targeting JAK1, they basically arrested the Th1-driven tissue scarring without messing with other vital pathways, like blood cell production, which relies on JAK2.
So what was the result?
Rapid alleviation. The case report shows significant improvement in her sclerosis and atrophic patches, and 0 new lesions developed over a 10-month follow-up.
Wow. But, stopping the scarring is really only half the battle with LS.
Oh, absolutely.
Because the defining, just maddening symptom is the pruritus, the intense itch.
And this is where the drug offers what we call dual coverage.
Right, because by blocking JAK1, upadacitinib also intercepts a completely different signaling pathway, the Th2 axis.
Yes. Specifically, it targets interleukin-31 or IL-31.
Which our sources basically call the master itch cytokine.
It really is. IL-31 doesn't just cause inflammation. It physically interacts with sensory neurons in the skin.
That's crazy.
It creates a direct neuroimmune link that fires severe itch signals straight to the brain. And JK1 is an obligatory part of that signaling mechanism.
So this one pill snips the Th1 wire, stopping the tissue damage and the scarring.
Right.
And it simultaneously snips the Th2 wire, cutting off that agonizing neurological itch at the source.
It is a profound clinical leap for someone who has just suffered for years with zero relief.
I can't even imagine how life-changing that is.
And we actually see this dual efficacy mirrored in the pediatric data, too.
Oh, the pediatric care cases. Yeah, that curious report.
Right. Because managing LS in kids introduces a really brutal set of logistical challenges. The report highlights a child with both genital and extragenital LS who is treated with oral tafasitamab, which is a JAK1 and JAK3 inhibitor.
And at first, giving a kid a systemic immunosuppressant sounds kind of extreme.
It does.
But when you look at the alternatives, it makes sense. I mean, topical retinoids cause severe burning on sensitive mucosal tissue. You can't force a kid to do a painful application every single day.
You really can't. And phototherapy requires constant hospital visits. Plus, kids just have poor adherence to messy creams in general.
Exactly. But there's also the physical toll of the disease itself.
Yes. In children, the severe inflammation often leads to dysuria, intense pain during urination.
Ugh, that's heartbreaking.
It is. The child starts deliberately withholding urine, which cascades into secondary infections, chronic constipation, huge psychological distress.
So an oral pill just bypasses all that trauma?
Completely. And the broader data is staggering. There was a retrospective series of 13 patients on tafasitamab. By week 12, over 92% had almost completely clear skin and resolved their severe itching.
Wait, 92%?
Yeah, and over 85% saw a total resolution of their painful urination.
Within 3 months?
Within 3 months.
That sounds nothing short of miraculous. Which, prompts me to ask the necessary skeptical question here.
Okay, let's hear it.
If this is so great with a 90% success rate in these unmanageable cases, why isn't it the first thing prescribed to every single LS patient right now?
Well, we have to do a grounded reality check here.
Right.
First off, these drugs are currently prescribed totally off-label for lichen sclerosus.
Meaning they aren't officially FDA approved for this specific condition yet.
Exactly. But the much bigger hurdle is that oral JAK inhibitors carry FDA black box warnings.
The most severe safety warnings possible.
Yes, major adverse cardiovascular events, malignancies, and venous thromboembolism, blood clots.
Okay, that sounds terrifying.
It does. Any clinician prescribing these has to counsel their patient on the elevated risk of heart attacks, strokes, and cancer.
But the sources provided a lot of nuance on that safety data, didn't they?
They did. Those severe warnings mostly come from a specific safety trial, the oral surveillance trial, which looked at rheumatoid arthritis patients.
And those patients already have a high baseline cardiovascular risk, right? They're older, they've had decades of chronic systemic inflammation.
Precisely. Applying that specific risk profile to a generally healthy, younger dermatology patient who just has an isolated skin condition, it skews the perceived risk.
Right, because in the dermatology trials, the severe risks seem much lower.
Much lower. The common side effects are usually just mild upper respiratory infections, some nausea, or transient lipid elevation.
So what does this all mean? Because, wait, I'm thinking back to the beginning of our deep dive.
Okay.
Didn't we say earlier that standard topical steroids actually help prevent vulvar cancer in LS patients?
We did. Clobetasol is a proven prophylactic.
Right. So if a patient switches from the steroid cream to this unproven oral JAK inhibitor, aren't they losing that proven cancer prevention benefit? Doesn't the systemic immunosuppression maybe blind their immune system to a developing tumor?
That is an excellent point.
Yeah.
And it is the single most pressing unknown in the field right now.
Wow.
Until we have rigorous head-to-head clinical trials comparing oral JAK inhibitors directly to clobetasol, the steroid remains the safest, most reliable option for long-term disease control.
So prescribing the oral pill is a massive calculated risk.
It is. It's strictly reserved for patients suffering profound anatomical and psychological degradation who have completely failed all localized therapies.
So we're kind of stuck in this gray area.
We are. But there might be a safer middle ground coming.
Topical JAK inhibitors.
Exactly. Drugs like ruxolitinib and delgocitinib are currently in phase 3 trials.
Delgocitinib is a pan-JAK inhibitor, right?
Yes, it blocks all 4 types of JAK proteins, but because it's a topical ointment, you localize the blockade right at the site of the lesion.
So you get all that targeted therapy, unplugging the cellular switchboard for the scarring and the itch, but without the systemic pill side effects that trigger those black box warnings.
That's the hope. If those trials return positive results, it could completely change the standard of care.
That is incredible to think about. To sort of summarize this for you listening, oral JAK inhibitors like upadacitinib and tafasitinib represent a fascinating, highly targeted lifeline for severe, generalized lichen sclerosus that just doesn't respond to standard creams.
They really are a lifeline.
They penetrate the cell, uncouple the JAK-STAT pathway, and turn off the cellular switchboard for both the structural scarring and that agonizing itch.
And while this is all cutting-edge science, it highlights a crucial shift in medicine.
Exactly. We are moving from just treating the surface symptoms to actually rewriting the internal cellular communication network.
It's a whole new paradigm.
It really is. And I want to leave you with one final thought to ponder today, building on something the sources mentioned a few times.
Oh, the epitope spreading.
Yes. The sources talk about epitope spreading and how LS frequently overlaps with other autoimmune conditions in the same patient, things like vitiligo or alopecia, which, by the way, are already treated with J inhibitors.
They cluster together all the time.
Right. So if autoimmune conditions often cluster together like that, driven by these same underlying intracellular errors, might the future of dermatology shift completely?
How do you mean?
Well, what if we move away from diagnosing a specific skin disease just based on where it appears on your body?
Oh, that's an interesting concept.
Instead, what if doctors map a patient's entire unique immune profile, pinpoint the misfiring pathway, and prescribe a single master switch pill that clears up their skin, their hair, and their tissue all at once?
Treating the code instead of the symptom.
Exactly. It makes you wonder what else we might be able to switch off in the future.